Hi, welcome to topic 5. In this topic, we're going to cover off head injuries, spinal injuries, and seizures. If you have any problems or have any questions, don't hesitate to contact us. Seizures. A person diagnosed with epilepsy has a tendency to have recurrent seizures, and this arises from a disturbance in the brain. This topic doesn't only deal with casualties who are diagnosed with epilepsy. 1 person in 20 will have a seizure at some point in their lives. There may be many causes of seizures, such as hypoxia, stroke, head injury, or even the body's temperature becoming too high. Absence and complex seizures. Absent seizures. A person experiencing an absent seizure may appear to suddenly start daydreaming, sometimes even mid-sentence. This may last just a few seconds before recovery, and the casualty might not even realize what has happened. Complex seizures. The characteristics of a complex seizure may start very similarly to an absent seizure, but may be accompanied by strange movements, such as twitching of the face, jerking of an individual limb, or lip smacking. The casualty may make a noise, such as letting out a cry or giggling. When caring for a casualty who is suffering absence or complex seizures, you're going to remove any sources of danger, such as a knife or a hot drink. Call an ambulance if there is no seizure plan. Help the casualty to sit down in a quiet place and reassure them. Stay with the casualty until they are fully alert. Note the duration of the seizure and pass this information on to ambulance crew. Note the duration in the incident report. Grand mal or tonic-clonic seizures. This type of seizure results from a major electrical disturbance in the brain, which causes aggressive fitting, usually of the whole body. Witnessing a major fit can be frightening for the first aider, but calm, prompt action is essential for the best outcome for the casualty. Generally, seizures occur in a pattern. The pattern generally starts with an aura. If the casualty has had seizures before, they may recognize that they are about to have one. The warning sign may be anything from a strange taste in their mouth, a smell, a particular feeling. The aura may give the casualty a chance to seek help or simply lie down before they fall. You have the tonic phase. Every muscle in the body suddenly contracts and becomes rigid. The casualty may let out a cry and will fall to the floor. Their back may arch and their lips may go blue. This phase typically lasts about 20 seconds. Then you have the clonic phase. The limbs of the body make sudden, violent, jerking movements. Their eyes may roll, their teeth may clench, they may produce saliva. Sometimes it's blood-stained because they've bitten their tongue or their cheek, and breathing could be loud, like a snoring sound. The casualty may lose control of their bladder or bowel. This phase can last 30 seconds to hours, although most seizures stop within a couple of minutes. Any seizure lasting more than 15 minutes is a dire medical emergency.
Madison.
Caring for a casualty having a seizure. You're going to help the casualty to the ground if they recognise that they need to, or if it's possible. Gently cushion their head to help avoid injury, and this can be done with a folded blanket or a jacket. Loosen any tight clothing around their neck to help them breathe. Move any objects from around the casualty that they may harm themselves on, and ask any bystanders to step back. If you're concerned about their airway, roll them onto their side, but only if you don't need to restrain them in that position. If they roll back, let the seizure work its way out, and then you're going to roll them back over and onto their side. Take the note of the exact time the seizure started and its duration. Look for identification if you don't know the person. As soon as the seizure stops, you're going to check their airway and breathing, and if they're not responding and not breathing, you're going to resuscitate if you need to. Place the casualty in the recovery position. Keep them warm unless, of course, it was a febrile convulsion and temperature caused the seizure. Monitor their airway and breathing. Move any bystanders away to try and protect your casualty's modesty. Check for levels of response regularly, and if the levels of response don't improve within 10 minutes, then you call an ambulance. You're also going to call an ambulance if the seizure lasts more than 15 minutes. If the casualty's response levels don't improve within 5 minutes of the seizure finishing, the casualty has a second seizure or more seizures than normal, injury has occurred, or they have food, water, or vomit in their mouth, the casualty is pregnant, not diagnosed as epileptic, or this is their first seizure, or if you're just not very sure, absolutely call an ambulance. Never place anything in the casualty's mouth, particularly your fingers. Never try to hold the casualty down and restrain them during a seizure, and never move the casualty unless, of course, they are in danger. Let's take a look at spinal injuries. So a spinal injury will occur with approximately 2% of trauma patients. Although this figure appears relatively low, suspecting and correctly treating the injury is essential because poor treatment of a casualty with a spinal injury could result in them becoming crippled for life or even end in death. So the spinal cord needs to be seen as an extension of the brainstem. It travels down the spinal vertebrae. Vital nerves controlling breathing and movement of limbs travel down this spinal cord. The weakest part of the spinal column is the neck because it doesn't have the protection of the torso. And indeed, a neck injury can be the most severe type of spinal injury because the nerves controlling breathing may become severed. All trauma casualties should be treated as having a spinal injury. However, the management of airway, breathing, and providing CPR always takes priority in caring for a casualty with a spinal injury. So a spinal injury should be suspected in a casualty that has been in a motor vehicle accident, motorbike accident, or bicycle accident, any accident where the casualty is unconscious, any accident where the casualty has fallen from a greater than standing height, so a jump from a diving board, or a jump into shallow water, or a fall from a horse. An accident involving speed, so where the casualty has been knocked down by a vehicle or something similar, a sporting accident, or a fall in an elderly person. Signs and symptoms. So remember, if some of these signs and symptoms are present, nerves may already be damaged. You should treat a casualty who you suspect has a spinal injury to prevent signs and symptoms from developing. So they might have pain or tenderness in the neck or back, tingling or numbness in the limbs and below the site of the injury, change in muscle tone, either flaccid or they become quite stiff sometimes, loss of bladder and or bowel control, depending on the location, shock and breathing difficulties. So if you're treating a casualty that you suspect has a spinal injury and your casualty is conscious, we're always going to start with doctors ABCD, making sure that you're safe, that they're safe and they've got a good airway. Reassure your casualty. You're going to keep them in the position that you found them and don't allow them to move unless, of course, they're in danger. Call 000 for an ambulance. Hold their head still with your hands and try and avoid them unnecessarily moving. Keep the casualty still and warm until the ambulance arrives. Now, if indeed your casualty is unconscious, If they're laid on their back, then their airway is in danger from the soft tissue falling into the back of their throat, or if they vomit. So if they have a spinal injury and they're unconscious, you're still going to place them in the recovery position. Now, you need to make sure and take care to avoid twisting. So if you're on your own, this can be achieved by putting their arm up, and their head is going to rest on their arm and they won't twist so much. If you have a few people that can give you a hand, you can do a log roll, and this is where somebody's going to be in charge of controlling their head, someone at their shoulders, someone at their hips, and someone at their legs. And everybody is going to move in unison, and this is going to allow the casualties to keep nice and straight as they're rolled over and onto their side. Next up, we'll look at head injuries. So the brain controls all functions of the human body. A head injury may result in brain damage that is permanent or even fatal. The signs and symptoms of a head injury may be apparent immediately, or it can be delayed and develop over several hours, sometimes even days. Injuries to the head often lead to unconsciousness, which in turn compromises your casualty's airway. It is important to remember that any casualty with a head injury may also have a spinal injury. So there are 3 conditions that we're going to look at in terms of head injuries. We're going to look at concussion, compressions, and fractures. Now I'm going to look at these fairly separately, but you need to remember that they do sometimes overlap one another. So if you've got somebody who does have a fracture, it's very, very likely that they're going to have a concussion as well. So look for the signs and symptoms that may overlap. A concussion is caused by shaking the brain. So the brain is cushioned by cerebral spinal fluid against the skull. However, when you take a knock, then the brain is shaken and it also can bounce off the inside of the skull. There can be 2 points of impact in the front and at the back where it's bounced off. The casualty may become unconscious for a short period of time. Usually this is less than 3 minutes, after which their levels of response should improve. The casualty should make a full recovery, particularly if there's no complications and there's no subsequent concussions. A compression injury is extremely serious. This is where the brain is placed under extreme pressure. This can be caused by swelling or bleeding between the skull and the brain, and that pressure pushes back on the brain. The cause of a compression can absolutely be a head injury, but it may also occur from illness such as a ruptured blood vessel, stroke, a brain tumour, or an infection such as meningitis. Then you have a skull fracture. This is quite serious because the broken bone may directly damage the brain or cause bleeding or swelling, which in turn can result in a compression injury. You should suspect a skull fracture with any casualty who has received a head injury, particularly if the casualty has lower levels of response. So I'm going to show you the signs and symptoms here. And you'll notice that some of them do overlap a little bit. So when you've got somebody who suffered a concussion, they may have had that period of unconsciousness, followed by an improvement in their levels of response and a fairly rapid looking recovery. They may suffer short-term memory loss, generally around the particular incident that had occurred, confusion or irritability, mild general headache, pale, clammy skin. They might go into a little bit of shock, rapid weak pulse. Now, we're not going to be checking pulses as a first aider, so while that's a valid sign and symptom, it's not something that you're going to be looking out for. Pupils should be normal and reacting normally to light, and they may have some nausea or vomiting. Now, when you have somebody who has a compression injury, they generally will have a history of a recent head injury, or they may have been unwell, but their recovery and their condition may in fact deteriorate and become worse. So the levels of response become worse as the condition develops. They may develop an intense headache or a worsening headache, flushed dry skin, deep noisy shallow breathing. This is where if there's pressure on the breathing area of the brain, this can cause their breathing to be disturbed. Slow strong pulse, again as a first aider, we're not going to be checking for pulses. One or both pupils may dilate as the increased pressure on the brain develops. They may stop reacting to light. And the condition generally becomes worse. As it becomes worse, they may start having seizures, and sometimes it'll get to a point where recovery is no longer possible. Then you have a fractured skull. They might also suffer a compression and a concussion, so be aware of that. They may have bleeding, swelling or bruising around the head, a soft area or depression on the scalp, Bruising around one or both eyes, despite the fact that it may not have been a facial injury, bruising around an ear or behind the ear. The swelling may become so developed that it can push the ear forward. Bleeding or fluid coming from a nose or the ear. Deformity or lack of symmetry to the head, so where once it was nice and round, it's not so much anymore. They may develop blood in the whites of the eyes. So when you're treating a head injury, it's so important to remember that they may also have suffered a neck injury. So when you have a casualty that's semi-conscious or not able to respond to you very well, they might not be able to tell you that they're having those other signs and symptoms. So we're going to start off with DRS ABCD. Make sure that you're safe, make sure that your casualty is responding, check their airway, and if you need to begin CPR, absolutely go in that direction. You need to call for an ambulance if the casualty has suffered any amount of unconsciousness, if their levels of response deteriorate or you suspect a fracture. To assess levels of response, you're going to ask questions to your casualty around person, place, and time. So they should know the answers to all of these questions around person, name, date of birth, place, where are you, time, what day is it, what month is it, what year is it, and they should be able to tell you what happened. Now, if they're responding to you inappropriately or they're not able to give you these answers, then you're going to have to start worrying about this head injury. Place them in a comfortable position with their head and shoulders raised, only if you do not suspect a spinal injury. If they're unconscious, place them in the recovery position and maintain their airway, monitor them really closely. Support their head and neck in alignment if you're not very sure of that spinal injury. Control bleeding, but avoid putting direct pressure on the skull, particularly if you suspect a fracture. If there is a fracture or you suspect that there might be one, you might use a donut bandage to use indirect pressure to control that bleeding. If fluid is seeping out of the ear, you're going to roll them onto the side that's seeping so that it can drain. You're going to put a soft pad underneath it so that you can catch it. And this fluid is most likely cerebral spinal fluid, and it's found a way to escape, which means then it's going to prevent a compression injury building up. So you're going to catch the fluid, but you're not necessarily going to plug it and try and stop it from coming out. So, useful tips. You're going to constantly monitor them, levels of response, ask those simple questions, and it's not a bad idea to engage them in a short conversation at the same time. And their responses to your questions in that conversation and how well they're able to keep the conversation going is also going to give you a really good indication as to the severity of this head injury. Even if your casualty appears to recover, watch out for their responses deteriorating, and also be careful. Sometimes the signs and symptoms of a concussion may be delayed, so they might not occur immediately, but sometimes they'll come up afterwards. Make sure that the concussed casualty is not alone for the next few hours. There's someone there to check on them and keep an eye, and they do need to see a doctor and seek medical advice. Advise your casualty to go to the hospital immediately if they suffer from a headache or a worsening headache, nausea, vomiting, or excessive sleepiness. And again, this might take a few days to occur, so they need to be aware of those symptoms and what to look out for. Don't allow your concussed sports player to play on or to even come back out on the field. There's been a lot of talk, particularly in the AFL, but in a lot of sporting spaces, about concussion and how subsequent concussions can become quite dangerous and may result in long-term complications or chronic illnesses. So making sure that they have been medically cleared before they go back to work, come back to sport is really, really important. In a school or childcare centre, any injury from the shoulders up must be reported to the child's parent or guardian straight away. An incident report form needs to be completed, and again, you're going to encourage this casualty to go and seek medical aid, particularly before they return to school or childcare.
I want to win.
I'm faster.
I'm going to lose.
I'm stronger.
We play hard.
The captain.
He doesn't scare us.
This small.
They want to win, they're going to have to match us.
They're definitely dirty.
Tempers get high, it's to be expected.
We look out for the weakness and we play on it.
You're not going to bend the rules, but you're certainly going to push them.
Joe. Joe! How you feeling, you alright? I knew what signs to look out for. You know, it's always better to get help. You know, just to be safe. Put this ice back on, yeah? Right here, just hold it like that.
What time's kick-off?
I think you need to get checked out, Joe.
I was lucky that there was someone that knew what to look for, knew how to help. Yeah, he might save my life. Which really makes you think.